Welcome, everyone. Thank you for taking time from your evening and what certainly is a busy week for everyone to join us for this webinar on cervical dystonia. My name is Janet Heischetter, and it's my honor to serve as the Executive Director for the DMRF. We are so pleased to present this program tonight and to have as our speaker one of the world's experts in dystonia present to us. Educating yourself on this disorder is really important, and I congratulate all of you on your efforts to stay informed and to be here tonight. We know from research that a well-informed and engaged patient does better on their treatment, and it's part of our mission to provide you with that accurate information so you can be and stay informed, and also to present you with opportunities to be engaged. Before we get started, I have just a few announcements to help us have a smoothly running webinar tonight. We are recording this webinar, and it will be made available to view again at a later date. To keep the background noise at a minimum, all attendees have been muted by default. If you're using your telephone to listen to tonight's webinar, please take a moment to make sure that the phone call button is selected in the audio section on your attendee control panel. You will also need to enter the audio pin that is shown. Please make sure that the speakers on your computer are turned down to avoid any interference. If you're using your computer's speakers to listen to the webinar, please be sure to select the computer audio button in the audio section of your attendee control panel. Your questions are an important part of this program, and we encourage you to write them in as you think of them, and we'll do our best to address all of them in the time that we have tonight. And I want to thank those of you who submitted questions in advance. We got some really terrific questions. I will moderate the questions to Dr. Comella, and we will get to as many as we possibly can. Those we can't get to tonight, we will respond to in either an article in the dialogue or a special email that will go out to everybody. If you have any technical difficulties during the webinar, please email Jody Roosevelt at jroosevelt@dystonia-foundation.org, the address shown on your screen here, and she will do her best to assist you. So let's get started. We are so pleased to have a global dystonia expert as our speaker tonight. Dr. Cynthia Comella is professor in the Department of Neurological Sciences at Rush University Medical Center here in Chicago. She is board certified in neurology and sleep medicine. Dr. Comella is the chair of the executive committee for the Dystonia Study Group and serves on the executive committee for the Dystonia Coalition. She has been an active contributing member of the leadership teams of both the American Academy of Neurology and the Movement Disorder Society, receiving the MDS President's Distinguished Service Award in 2008. Dr. Comella has been very active in clinical research efforts and has authored or co-authored many publications. Earlier this year, Dr. Comella received a grant from the Department of Defense for a research project on cervical dystonia, working with Dr. David Peterson. And I'd like to congratulate her on that award. And I'd also like to give a shout out to all of the dystonia advocates tonight for their efforts in creating this opportunity so that Dr. Comella could receive this award. I'm proud to say Dr. Comella is a member of the DMRF Medical and Scientific Advisory Council and has been a speaker at many foundation educational programs over the years. She's a wonderful resource, and we're grateful to her for her efforts in providing an overview of cervical dystonia and updating us on the research efforts in this field. I'd like to turn the program over to Dr. Comella. Dr. Comella.
Thank you, Janet. That was a lovely introduction. And I want to thank you, and I want to thank the Dystonia Medical Research Foundation for providing me this privilege of being able to address so many who are interested in cervical dystonia. I arranged my talk really around the questions that I am frequently asked in the clinic. So I'm going to try to address those, but I'm sure there are many more that can follow. Okay, next slide. So first of all, one of the questions that really often comes up, especially when someone is newly diagnosed, is how did you make that diagnosis? How is cervical dystonia diagnosed? It's important to realize that it is a clinical diagnosis. It's made through the history that we hear often of abnormal movements that may have fluctuated at first or may have come on very severe at the onset. So we make it by the history and we make it by the examination. What do we see? What do we feel? Is there anything else there? It's important to realize that there are no laboratory or brain imaging diagnostic tests that are currently available. So without that clinical diagnosis, it's very difficult to make the diagnosis. And this often will lead to a diagnostic delay, which can be as long as 7 years from the first time seeing a physician until the correct diagnosis is made. Oftentimes, people are either sent to orthopedics, unfortunately, sometimes to psychiatry, and to many other types of physicians before finally seeing either a neurologist or a movement disorder specialist. Now, the way we look at cervical dystonia is really by its physical manifestations. So it is defined as involuntary muscle activation of neck and shoulder muscles that result in abnormal movements. Typically, these are sustained postures, but can have overlying spasms that can resemble tremor. The movements have to be patterned and have a twisting component to them before we're able to make this diagnosis. So you can see, without having any experience in cervical dystonia and in dystonia itself, how a physician might be misled, if you will, into thinking that this must be something else. Can I have the next slide, please? One of the interesting features of cervical dystonia that again fooled many people for many years as to whether there was a psychiatric portion to the dystonia was the geste antagoniste or sensory trick. And here you see a lovely set of old photographs that were presented by Brissot in 1894 in one of his lessons. And you can see the people having fairly severe movements, and then just a mere touch of the chin or leaning back against a wall or touching the nose, as in that one gentleman, can improve the symptoms. So this was very confusing for a while, and people thought that, well, with these maneuvers, it means that, in fact, dystonia isn't a neurologic disorder, but rather a psychiatric disorder. We've come a long way. Now we recognize this as really one of the hallmarks of cervical dystonia. Can I have the next slide, please? Another question I get asked frequently is, what's going to happen to me? What's the prognosis? What does the future hold? It's important to recognize that cervical dystonia is often a lifelong disorder. There can be transient remissions in up to 20%, but these remissions can be very short-lived, lasting only days, or sometimes can last for many years. However, the dystonia does tend to come back. So permanent remissions are thought to be quite rare, probably less than 1% of those affected. However, it's important to also recognize that the severity of cervical dystonia symptoms can fluctuate quite a bit. In some people, when they get into a stressful situation, it can be a happy stress, it can be a sad stress, an angry stress, or even things such as infections or pain. It can bring out the symptoms of dystonia. That doesn't mean that it's going to be permanently worse, but it often is a cause of worry for those who experience this. It's unfortunate that we don't know a lot about the natural history of cervical dystonia. This is an area that the Dystonia Coalition has been really pursuing in a very systematic way through an NIH grant that they received a number of years back. Many people will also ask me, well, is this going to affect my entire body? And the answer is no. typically less than 6% have spread of the dystonia to other body areas. So it's very, very rare to become generalized dystonia when you start with cervical dystonia. So overall, it tends to affect one body area, and really in adults to stay in that area, although again fluctuating in severity. And then I also get the question, well, is this a neurodegenerative disease? Am I going to get Parkinson's? Is that what this means? And the answer is also no. At this point, there's no known association with Parkinson's disease or other neurodegenerative diseases, although some people may experience what we call an essential tremor associated. That's a tremor in the hands that's associated with the dystonia. Next slide. Another very frequent question is, do I have to worry about my kids? So is cervical dystonia hereditary? A study done about 20 years ago found that about 25% of people who have cervical dystonia reported either a family history of tremor or of other forms of dystonia. We know that almost everything we are is in our genes. However, there's only been very few mutations, genetic mutations, that have been associated with cervical dystonia in particular, and these typically, for the most part, are quite rare. So what I tell most people, what I tell all people, is that in most patients with cervical dystonia, there's likely a genetic susceptibility, but it has to be combined with other factors, either environmental factors or other genetic factors that bring out the symptoms of dystonia. So the bottom line, don't worry about your kids. Let's talk about the treatment of cervical dystonia. So there are really 4 major pathways for treatment: oral medications, botulinum toxin injection, deep brain stimulation, and we'll touch a little on rehabilitation therapies. So on the next slide, what you're going to see are the oral medications that have been used in cervical dystonia. And you can see they kind of divide themselves out. There is the cholinergic system that is hyperactive, that has been affected by, can be affected by dystonia. And we often use anticholinergic medications such as trihexyphenidyl to try to alleviate the symptoms. The problem with these kinds of medications, however, is the side effect profile is almost prohibitive when one is trying to treat an adult with a dose of trihexyphenidyl that will be therapeutic. We also look at the GABAergic system, and in this system, baclofen and clonazepam are the medications that we tend to use. But as with the anticholinergics, these medications carry with them significant potential for side effects if one tries to reach a dose that may be therapeutic. And finally, the dopaminergic system. Here we have tetrabenazine, which actually depletes dopamine and was recommended very early on insofar as being a treatment for dystonia. Tetrabenazine, unfortunately, carries with it a significant risk for things such as depression, as well as interaction with other medications. In addition, since its approval for Huntington's disease, it has become a quite expensive medication to use. Then I show you the other agents that have been used, and you can see that it's really a mishmash of different types of medication that in some people may be of some benefit. So we do try different medicines in those patients that prefer oral medications to treat their dystonia. However, it's important to recognize there are no oral medications that have FDA approval for the treatment of dystonia or for cervical dystonia. In the next slide. So botulinum toxin injections. botulinum toxin injections have emerged more or less as the treatment of choice when one is going to treat a specific body area of dystonia. As you can see here, there are 4 brands that have been FDA approved for cervical dystonia. 3 of these are serotype A, so they have a very similar mechanism of action. And then the last is renobotulinum toxin B, which cleaves a different enzyme, but the end result is the same, in that all of these result in muscle weakness in the muscles into which they are injected. I have given you both the generic names, which I'm not going to read because it'll sound like I'm singing a song, as well as the brand names of each of these types of botulinum toxin. At this point, I often get asked, is there one that's better than the other? And at this time, there is no proven difference in the outcomes of treatment among these different brands. So again, although they have differences in how they are prepared, there is very little in the literature that suggests that one is better than the other. And again, to reiterate, botulinum toxin injections work in approximately 70% of patients. They help posture, pain, and activities of daily living. But it's important to recognize that the results don't occur right away. It typically takes about 2 to 3 days before one feels anything, and then the optimal results occur about 2 to 4 weeks after injection. Unfortunately, after about 3 months, the botulinum toxin wears off and there's a waning of benefit. But this provides people with at least 3 months of relief from their symptoms. Then they have another injection and they reinstill the benefit that they get out of the treatments. The side effects from botulinum toxin can include difficulty swallowing and neck weakness. These are often avoidable and they will resolve prior to the waning of benefits of the toxin. The next slide. So a couple of the tips for a botulinum toxin, if that is the avenue you choose to pursue, is it's important to know who's doing the treatment. So in order to be able to use botulinum toxin effectively, a treating injector needs to know what cervical dystonia is, needs to understand the functional anatomy, that is, what muscle does what movement. In addition, they have to know the types and the dosing of each botulinum toxin, as well as discuss with patients the possible side effects. Now, it's important to recognize that botulinum toxin is covered by Medicare and most insurers, because cervical dystonia, again, is an FDA-approved indication. But that does not obviate the need to get a pre-authorization from your insurance company. And this can take from 2 to 4 weeks. So this is one of the key elements that you need to understand as you prepare to get treated. In addition, I think it's very important for all patients to understand that each of the companies that produce serotype A have a reimbursement program that can cover in part co-payments and deductibles. It's important to ask your physician about these, or at least a referral for these, or to ask the Dystonia Medical Research Foundation, because this will provide you, again, with some relief of any of the costs for the treatment. Next slide. Let's turn now to deep brain stimulation surgery. DBS, or deep brain stimulation, is indicated for patients who do not receive adequate benefit from other treatments. So it's not our first line. In this procedure, microelectrodes are placed in the globus pallidus interna. The globus pallidus interna, or GPI, is a part of a deep part of the brain called the basal ganglia. The basal ganglia has much to do with the control of movement. In dystonia, the GPI has abnormal activity. Placing a lead there that provides stimulation can reset the activity of the GPI. There is a programmable pulse generator that's also implanted bilaterally. It's by the collarbones. But if you walk into a room and you see a bunch of people there with cervical dystonia, you will not see any external equipment. This is all internal. So everybody pretty much looks the same. They do very good work with this. After the surgery is done, programming the stimulators until optimal settings are achieved may take a few months. But typically, this type of procedure can be helpful for cervical dystonia. Let's see the next slide. So this just shows the results of deep brain stimulation for cervical dystonia. And in the red circle, you can see the GPI stimulation. And you can see that the benefits are approximately 40%. This is not quite as large of a benefit as with the generalized, especially DYT1 dystonia, but it is significant benefit. Let's go to the next slide, please. There are, of course, adverse effects that are associated with any procedure you do. There can be surgical effects such as infections or bleeding. There can be device-related effects such as breakage of the leads or infection of the hardware that can occur after the surgery. And finally, there's stimulation-related effects that are due to the stimulation itself. These include things such as slurred speech and Parkinsonism, and these are reversible with changing the settings on the stimulator. Keep in mind that these complications affect few. They don't affect many. So it's not that these should be kept in mind, but I don't think they should make you feel that this is not something you would ever want to do. Let's go on to the next slide. What about physiotherapy? Physiotherapy has been a very difficult area to study in cervical dystonia. There have been 6 clinical studies using all of these different techniques, and although not found effective for head posture, can improve pain and disability. However, there's methodologic problems with most of the studies that have been done, and this is largely due to the robust effect of botulinum toxin wiping out or diluting the results of physiotherapy. I do recommend it in many of my patients because of its benefits for pain and range of motion. In the next slide, please. So let's talk about what's going on in dystonia. Where's the future? Well, I have given you classification, genetics, animal models. All of these areas have seen significant progress over the past decade in our understanding of dystonia. On the right side of your screen, you'll see a series of panels. This is a new theory as to how dystonia occurs. So dystonia is not a neurodegenerative disorder, but rather a malfunctioning of different nodes that communicate with each other in order to arrive at normal movement. So it can be either one node that's not working as well as it should, or it can be that the communication between nodes is aberrant, causing the problem, or it may be that 2 nodes can be affected, and that you see in your last panel. Now these nodes, you say, well, what's a node? They include things like the basal ganglia, the cerebellum, the cortex, and the pons, as well as other structures. So brains don't just talk to themselves, they talk to each other. Different regions communicate with each other. Disruptions in these can result in dystonia. Next slide, please. So one of the things we're doing that's really quite interesting is, and this is part of our Department of Defense grant, is Computer Expression Recognition Toolbox, or CERT. This was initially thought of and has been worked on very assiduously by David Peterson at the Salk Institute. I am the co-PI and really pleased to be able to work with David. This is a computer-derived quantitative assessment of cervical dystonia. So on the right side of the slide, what you see is that the computer actually looks at the face and it's able to monitor where the eyes are, because these are all in a straight line, where the chin is, and where the head is tilting. So in the woman on the right, what you can see is that it can measure different angles of movement. So the pitch being the anterocollis or retrocollis, the yaw being the turn in the horizontal plane, and the roll being the tilt of the head. So you can see it can measure multi-dimensions of dystonia. And in the lower box, you can see that before botulinum toxin, this particular patient, indicated by these red lines, had a significant turn to the head. In the box after botulinum toxin, you can see that this has been significantly reduced. Well, you say, well, what's the importance of that? It provides us with a quantitative way to be able to measure the outcomes just using computers and video images to determine benefit from any treatment that one receives. It also allows us to study tremor associated with dystonia. We are looking at pain, and we're also able to determine the predominant movement of the head, which is going to be helpful to the clinicians for treatment. Could I have the next slide, please? I wanted to just show you, and I'm going to do this briefly, some new developments that have come out really quite recently. This paper is from 2017, and it comes from Dr. Standard's lab at the University of Alabama in Birmingham, and based much on the work of Pisani, who is an investigator in Italy. And they found that in animal models, in fact, one can detect that there is an overabundance of cholinergic tone. We had talked about that earlier insofar as using anticholinergics. Well, this provides a basis for using this type of drug. The key is to develop a drug that does not carry with it the side effects of trihexyphenidyl and yet can affect this elevation in cholinergic tone. Next slide, please. And this just shows, this is a really messy slide, so I'm going to really briefly talk about this. So in the left panel, what you can see, and this is the basal ganglia again, you can see that there is an indirect and a direct pathway. These two balance each other. The direct pathway causes excitation of the movement area of the brain. The indirect causes inhibition. So what is responsible for this modulation? If you look at the right panel, you'll notice this big green acetylcholine interneuron. So that is the cell, even though there's less than 5% of them located in the basal ganglia, but that is the cell that modifies all of these different pathways. And you can appreciate from this slide the number of potential receptors. The receptors show up as little balls on the ends of these little terminals. So there are so many therapeutic options for dystonia. Next slide, please. So what about the cerebellum? We always used to say, well, the cerebellum is only the balance center of the brain. It's located in the back of the brain, and we thought it was different than the basal ganglia. But work has demonstrated that the basal ganglia and the cerebellum have many cross axons. So they communicate with each other. And we think that this interconnection is quite important and again provides us with a new area to look at for therapeutic interventions. Can I see the next slide, please? So this is just a picture of some of the receptors located in the cerebellum. And what I've done is I've circled ones called the AMPA receptors, because in mouse models, if one stimulates those receptors, one gets dystonia, and specifically within the cerebellum. If one blocks these AMPA receptors, one improves the dystonia. Next slide, please. So what we've done is looked at a drug, it's called ParathaNo. So it's an AMPA receptor antagonist. So it means it blocks the AMPA receptors, just as in those mice. It reduces glutamine signaling, and it's already been FDA approved as an adjunct therapy for partial seizures. When used in the paroxysmal hamster model of dystonia, ParathaNo actually reduced the dystonic severity. So quite promising background. The next slide, please. So we are doing currently a study, and this is a 5-center study, investigator-initiated, looking at ParathaNo. If we give ParathaNo to patients with cervical dystonia, first of all, will they be able to tolerate the drug? And is it safe? And secondly, will this drug improve cervical dystonia severity? This study has already started. It started in September of 2017, and we have 3 patients currently enrolled. So we have a bit of a ways to go, but I think the information will be invaluable. Next slide, please. So in conclusion, I want to just give you a few of the take-home messages from this presentation. First, cervical dystonia is a clinical diagnosis. This has led to diagnostic delay due to an unfamiliarity with the disorder. Second, the treatments include oral medications, none of which is FDA approved, botulinum toxins, and DBS. Physiotherapy may have a role, but the precise role has to yet be determined. And finally, research has opened up many new and novel treatment targets for dystonia. So you can see we've come a long way, and there's a lot of hope. I want to thank the Dystonia Medical Research Foundation for being incredibly active in promoting research and promoting education. I don't know what we do without them. I'd like to thank, of course, everybody at Rush, and finally, the Dystonia Coalition, who has been very, very aggressive insofar as helping us better understand dystonia. And on that note, I'll say thank you. And any questions?
Well, thank you, Dr. Comella. That was really just terrific. Really wonderful overview and a nice update on the research that's taking place. So thank you for that. So we do have a number of questions. Let me just give you the first one here. This comes from somebody who is newly diagnosed and has been through 4 rounds of botulinum toxin injections and hasn't really felt much benefit. Is there advice that you would provide, give someone like that? Do they need to hang in there a little bit longer? Should they pursue some other treatment?
Well, botulinum toxin treatments, again, are very dependent on who is doing the injections. So sometimes it's worthwhile just getting another opinion from someone who is also doing the injections to see whether there can be a better injection pattern, perhaps better dosing of the medications. Because often one can find muscles that some people may not be as aware of that can actually, make the day, so to speak. In addition, it's important to recognize that certain kinds of dystonia, in particular, the one where the chin is bent forward down to the chest, that form of dystonia is particularly challenging to treat with botulinum toxin. At that point, we typically turn to our medications, or in circumstances where severity is really limiting, the deep brain stimulation surgery.
Great, thank you. Could you talk about the difference, if any, between torticollis, spasmodic torticollis, and cervical dystonia? A lot of these terms are used in the community, and there's some confusion by them.
Yeah, it is confusing, isn't it? Torticollis was the terminology originally used, but in fact, torticollis means turn of the head. And we all know that there is more than one way for a head to go. It can tip, it can bend forward, it can bend backward. So torticollis has been largely abandoned as a terminology, and cervical dystonia actually describes cervical, meaning neck, head, and shoulders, dystonia, of course, meaning the disorder. So that is the terminology that's preferred. The spasmodic part of torticollis has to do with the overlying spasms that one can see in certain individuals. But not everybody has those overlying spasms. So to call it spasmodic torticollis really gives not a true picture of what many people suffer with.
Right. Great, thank you. Could you talk a little bit about the use of medical marijuana in treating cervical dystonia?
I think I get that question asked quite a bit. So right now there is no clinical trial that suggests that medical marijuana will be of any benefit in cervical dystonia. The one study that was done was quite small. It was done in Canada, and it actually did not show any benefit. So at this point, to use medical marijuana with all of its potential side effects, particularly the cognitive side effects, when you're not even clear whether it's going to be of any benefit, is really not recommended. So we go to other forms of therapy, and hopefully we'll understand better whether there is any role for medical marijuana in dystonia.
Great, thank you. And there are a number of videos out on the internet that talk about the dentist developing mouth guards that can be used for the treatment of cervical dystonia. So that, I think, combined with another question, which is, can cervical dystonia be caused by complications of TMJ?
Both are very interesting questions. The dental devices, the only way I can even, if I went out on a limb, guess that they would be a benefit is they can serve as a sensory trick. Just as you saw in those panels of patients previously, touching the chin, touching the back of the head. In some patients, they may serve as a sensory trick. But for most of the patients I've had who have tried them, and they're very expensive, there has not really been much success. And so far as temporomandibular joint syndrome, it's really dealing with a different part of the anatomy. It's dealing with, and some have said oral mandibular, which involves mouth dystonia, may be in some way associated with temporomandibular. But at this time, I don't think there's any reason to think that TMJ will be associated or cause cervical dystonia.
Okay, great, thank you. So this next question taps into your sleep expertise as well. Mm-hmm. Have you heard of any research showing that the ingredients in lunesta, the sleep medication, can help with cervical dystonia?
Well, you hear all sorts of stuff. So zolpidem, Ambien, has been reported to help oral mandibular dystonia of the mouth and the jaw. I have not seen any reports on lunesta, and certainly it hasn't been very popular. And I think that's because if you go to sleep, your dystonia will, of course, improve, but one cannot be groggy throughout the day. So thus far, it hasn't been one of the drugs that I've chosen to try in patients with dystonia.
Okay, thank you. And what about the, could you comment on the long-term effects of botulinum toxin? This question comes from somebody who's been on it for 10 plus years and wonders if it will not work as well in the future, or if it might cause, long-term harmful effects for a long-time use.
Mm-hmm. Well, I started using botulinum toxin in the late 1980s, and I still see some of those patients that I treated way back when, and they still get a good response. So botulinum toxin early on, if you got frequent injections, could cause the formation of antibodies, and that would cause the botulinum toxin not to work. However, since the 1990s, the late 1990s, each company has formulated good clinical practice. So it's a fresh batch that you get every time. So the occurrence of resistance is much, much lower. It's estimated to be less than 2% of patients. So there is no reason that one couldn't get a continued response to the drug. Now, in some people, the dystonia may change. Some people note that when it used to be this way and now it's that way. And if the doctor doesn't pay attention and you continue the same pattern of injection, that can lead to a lack of response. But I'll warn you that every patient will have one series that doesn't work. And then they come back and it works again. Typically, it's related to some stressor that's outside of the clinic and not because of the method of treating. Insofar as long-term sequelae, if you stop botulinum toxin, everything that it did will go away. So there will be no changes in the muscles if you receive botulinum toxin for a prolonged period of time. There's some evidence in blepharospasm that it may cause some fibrosis of the muscles. In cervical dystonia, we really haven't seen that if one lets the toxin wear completely away. And that can take as long as 6 months.
Okay, thank you. There's a new medication, valbenazine. Could you comment on its use? Well,
valbenazine is a VMAT inhibitor, and what a VMAT inhibitor does is it depletes dopamine by preventing the repackaging of dopamine to be released again into the synapse. And so you have a reduction in dopamine. It's been approved for tardive dyskinesia. At this time, it has not really been looked at as a drug to be used for dystonia. So the approvals really were just last April for tardive dyskinesia. My suspicion is that this is a drug that will likely be looked at. Will it be successful? I don't know.
Okay, thank you. So why does alcohol help some people with cervical dystonia?
Well, I have heard this previously. I think it has to do more with the general effect of alcohol to relax. So most people, when they feel relaxed, their dystonia is less than when they're all hyper and excited. And in some ways, that's the way clonazepam works, we think, is that it reduces the stress and the adrenaline surge, and so can secondarily improve the dystonia. However, there may also be a pharmacologic reason that at this time we don't quite understand.
Okay. So we have a question from somebody that really addresses the environmental issues that might trigger cervical dystonia. Do we know of any toxins pesticides or what have you, that might be linked to the development of cervical dystonia at this point?
Well, we really don't have any toxins per se. There are some toxins such as manganese which cause dystonia, but they also cause a lot of other things like Parkinsonism and different types of neurologic abnormalities. So no, that would not be something I'd be looking for. There's been some literature about head and neck trauma being a susceptibility factor for dystonia. But the problem when you look at these epidemiologic studies and you ask people questions, those with cervical dystonia are more likely to be thinking, did I ever hurt my neck, rather than people who don't have dystonia. So again, that hasn't been a causal association, but it is an association. There are certain drugs, such as haloperidol, the psychotropic medications, which can cause something called tardive dystonia. And in some people, it will manifest predominantly as cervical dystonia. But these people have a history of being exposed to these drugs, and they're not often, people without psychiatric histories don't often get exposed to these drugs. And then note the onset associated with the use of the drug. So again, most people don't have tardive cervical dystonia.
Great, thank you. We've had a number of questions about pain and pain management, and I would combine that with how somebody might, you mentioned the use of physical therapy and helping pain relief. Would you talk a little bit about how you find a physical therapist, and then also address the issue of what other things people might be able to do to alleviate pain?
Well, I think pain is particularly responsive to botulinum toxin injections. So oftentimes we will use it and improve the pain. Now, sometimes the pain can be the result of other issues. For example, sometimes people with cervical dystonia can have a slight increase in the occurrence of cervical arthritis. And this can cause pain. And so the treatment of that pain would be anti-inflammatory medications, heat, and likewise. I have found that a good physical therapist who does stretching, range of motion exercises can also improve pain. It is difficult to find, however, physical therapists who are trained in cervical dystonia. So I often ask that the therapist give me a call so I can explain we're not trying to strengthen muscles to defeat dystonia. We're trying to stretch muscles to alleviate the pain. But again, it's difficult sometimes to find just that right person.
Yeah, it certainly can be. How about the use of acupuncture in both relieving pain and symptoms of cervical dystonia?
That's a really good question. It hasn't been studied adequately, and in the patients that I have had who have done acupuncture, they do find some short-term relief from the acupuncture. But I really think that we need to have a better study to determine the role of acupuncture. It may be as an adjunct to other treatments, but I'm somewhat pessimistic about it being the sole therapy just based on my clinical experience.
And what about the use of chiropractic and seeing a chiropractic doctor? Does that help, or are there any studies that on that we're aware of that might help dystonia, cervical dystonia?
Well, you get personal testimonials, and you hear a few case reports, but for the most part, again, it hasn't been studied. I do think that one of the dangers, especially in neck manipulation, is actually damage to the vertebral column and potentially to the spinal cord. And this is particularly true after one gets botulinum toxin and you're weakening those muscles which protect the spine. So I think for chiropractic in general, if someone says, well, I find this very helpful, as long as there's no manipulation involved, it's fine with me. But I don't, at this point, recommend it as an independent therapy.
Thank you. And then also, would you talk a little bit about the use of EMG versus ultrasound? And just, some doctors are still palpating and feeling for muscles before they inject. Is there one better than the other, or, what's the difference?
Yeah. Well, some physicians, some neurologists will inject just based on feeling whether a muscle is big or not big. Unfortunately, the muscles of the neck are layered. So feeling from the surface, it's really hard to know which muscle is big under there because there are several, and some of them have the same direction of action. So there's more than one muscle that pulls ahead to the right, for example. EMG, I'm a big proponent of EMG because what EMG allows you to do is it allows you to get at these deeper muscles. And if the patient's in the dystonic posture, to hear the overactive muscles. And then finally, to be able to target the injection directly in to the overactive muscles. Now, ultrasound is relatively new, and people are beginning to use it more and more. What that does is it allows you to see the muscle bulk. So you can actually identify individual muscles in the neck if you're trained. And then you can see the needle going in and you can see it going into the neck muscle. For those who are adept at it, I think it's likely a very helpful method. I find that I need another arm in order to be able to do it because you have a lot of different things that one has to manipulate. So I haven't used it quite as much. Whether or not it's superior to EMG, I don't think that has not been demonstrated yet.
Okay, thank you. Next question is, how important is it to utilize psychological assistance in the path to good treatment?
I think it's really important to give that a consideration. We're finding now that things like anxiety and depression may in fact be a part of cervical dystonia. And if we ignore that part, we may make, neck muscles work beautifully. But if the depression and the anxiety persist, it's really quite important to get those treated in order to maximize your quality of life. Now, there are other reasons for counseling, and that includes, it's really hard when you get a diagnosis like cervical dystonia. It's really hard to sort of come to grips with that, at least it would be for me. And sometimes it's very helpful to work with a counselor in order to better understand what your reaction is to having a disorder that you may have to live with for a long period of time.
Thank you. How often, or does it at all, does cervical dystonia appear in children?
Cervical dystonia is very rare in children. So when you see a child with their neck twisted, it can be congenital, meaning there's a shortening of a muscle. It's not really a dystonic overactivation, but it's actually a shortening of a muscle. The other thing to keep in mind, particularly in children, is that the top of their spinal cord, where the spinal cord meets the skull, is very flexible. And so in some children, they can actually slip one bone off the other bone, their head will be tilted, but it has nothing to do with dystonia. It has to do with this skeletal abnormality that needs treated by an orthopedics and not by a neurologist. So it's really important when you see cervical dystonia, if you see a neck dystonia in a child, an isolated neck dystonia, not in the face of generalized dystonia, to have that child really investigated well.
And would you talk a little bit about the role that diet, nutrition, and lifestyle, exercise can have on cervical dystonia?
Well, I am one of the biggest proponents of exercise. I have done a lot of work with exercise, mostly in Parkinson's disease. But based on the effects of exercise on mood, on muscle control, on cardiovascular, on thinking and memory, I think all of us need to keep in mind that exercise is something we should incorporate into our lives. And I think people with neurologic issues in particular should make that a part of their treatment program. Insofar as diet, that's a little bit tougher to answer. There is now diets coming out all over, but one of the diets is called the MIND diet. This is actually more intended for people with Alzheimer's disease, but it's also coming to the forefront in Parkinson's disease. And that's a diet, of course, that emphasizes all those things that people may or may not like, such as, high fiber, green vegetables, minimal meat. Just think
the week
of
of
all
Thanksgiving you're talking about this.
Yeah, there goes the Twinkies. But none of the carbohydrates. It's a low carbohydrate, high fiber. But it's not been, for cervical dystonia, it really hasn't been looked at in any way.
So an area that we need to yet investigate. So.
We have so many, don't we?
Yeah. As you said, there's so much good news to really celebrate new drugs being tested, but we certainly have work ahead of us. Last question. The person is asking if there is, if it's known whether or not cervical dystonia can cause damage to joints and soft tissue. You talked a little bit about arthritis in the neck, but could you comment a little bit more on that?
Yeah, it is true. When one uses a joint and they use it, it tends to wear out a bit. And in cervical dystonia, because these joints are constantly being used, it appears that cervical arthritis of the bones or wearing out of the bones can be a little bit more frequent. In addition, sometimes if you pinch a nerve that's coming out from these bones, it will cause, this kind of a shooting pain down an arm. One should always talk to their physician if they find that, again, they're having neck pain, not clearly related to dystonia, or in particular, if they have any type of weakness in their legs, weakness in their arms, or shooting pains. Great.
Thank you. Dr. Comella, thank you so much for this. This has really been terrific. We have a number of other questions and topics that we did not, unfortunately, because of time constraints, get to, but I just want to let everyone know on the line that we will do our best to respond to those and get answers out to everybody. And would also just like to give a plug to joining a support group. If you haven't, there is an online group for cervical dystonia patients. We're happy to provide you with that information if you're interested. Being connected with others and staying informed, as we know, is a very important part of someone's successful treatment program. So you have been just terrific. Thank you so very, very much. And this concludes our program for this evening. Thank you all for your questions and for sharing your evening with us. And Dr. Comella, thank you again for a really wonderfully informative program. I wish everyone a wonderful Thanksgiving, and thank you again. Good night.
And thank you, Janet. Good night.